to start our next speaker presentation for the Spiritual Awakenings International Conference. And I'm absolutely delighted to be introducing our next speaker, Dr. Francis Liu. And Dr. Francis Liu has had an outstanding medical career, and he has been a true groundbreaker in the field of spiritually transformative experiences, spiritual emergence, spiritual awakenings, cultural psychiatry. And it is my great pleasure today to be inducting Dr. Francis Liu into our Spiritual Awakenings International Circle of Honor. I'm just going to bring him on so you can see his face while I'm honoring him. So as I mentioned earlier, Spiritual Awakenings International has a Circle of Honor, which is our equivalent to the Hall of Fame. And this is where we acknowledge people that our board feels have been true groundbreakers and pioneers in the field. And so today it is my great honor really to give a tribute and recognition of Dr. Francis Liu's contribution. As I mentioned previously, we do plan to have an in-person induction ceremony in time, but we don't know when COVID's going to be over. So at this point, we're doing the induction ceremony when the honoree is speaking. So let me tell you a little bit about Dr. Francis Liu. May I say to you that his resume is so long and so detailed that I'm just picking some of the most important points for you today so that you'll have time to hear him speak. So Dr. Francis Liu is a psychiatrist living, I believe, in San Jose, California. Correct me if I'm wrong. He is a professor emeritus of psychiatry and behavioral sciences at the University of California, Davis. And for those of you who don't know what a professor emeritus is, that is an honorary standing. So he has been recognized. He has many, many recognitions. He is also the Luke and Grace Kim Endowed Professor in Cultural Psychiatry Emeritus at the University of California at Davis. He is the Distinguished Life Fellow of the American Psychiatric Association. He says he was deeply influenced by various events he had the good fortune of attending at Esalen in California, including a seminar put on by Joseph Campbell, and then later on by lengthy interactions with Stan and Christina Grof, the two co-founders of the Spiritual Emergence Network. And since 1987, he himself, Dr. Francis Liu, has been leading seminars at the Esalen Institute in California. And we are particularly honoring Dr. Liu today for work he did in the 90s, which punctuated his outstanding career. In 1992, together with Dr. David Lukoff and Dr. Robert Turner, Dr. Francis Liu and the other two doctors submitted a proposal to the DSM-4 task force that was developing the diagnostic criteria. For those of you who don't know what the DSM-4 is, it's like the Bible for psychiatrists and psychologists, the diagnostic category. So for it to exist in the medical and psychological field, it has to make it into the DSM. And this groundbreaker, Dr. Francis Liu, together with Robert Turner and David Lukoff, they're the ones that got it into the DSM. And that was profoundly influential for me as a physician trying to work groundbreaking in this field, for Dr. Bruce Greyson and other pioneers. This was an extremely important step, groundbreaking step. So the three of them submitted this proposal in the DSM-4 task force for a new diagnostic category that would provide a non-pathological diagnosis, which could include what we now call spiritually transformative experiences, or what could be called spiritual emergence, or distressing experiences, which one might call spiritual emergencies. And you see, before this point, the only way you could find a spiritual or religious experience was pathological, that it was a hallucination or post-ictal religiosity. There was no non-pathological way to categorize it. And so this was they were proposing, which was very, very groundbreaking. And in 1994, the DSM-4 that came out in 1994 did indeed include this seminal, groundbreaking new category that they had proposed. I know they modified it a bit, but it was enough. It got the foot in the door. Religious or spiritual problem, which was V code 6289. Under other conditions that may be a legitimate focus of clinical attention, and it was by definition not a mental disorder. So STEs and spiritual emergencies are not a mental disorder. And both this diagnostic category and the definitions that he helped develop were retained in the more recent 2013 DSM-5. And it is particularly for this work that the Spiritual Awakenings International is recognizing and honoring Dr. Francis Liu on our Circle of Honor today. But his work didn't stop after that. He continued on and has done outstanding things. He has a great long list. There just isn't time to read them all. Both in 2002 and 2016, he was awarded the American Psychiatric Association's Special Presidential Commendation for his contributions to cultural psychiatry. In 2020, he received the American Psychiatric Association's Distinguished Service Award. And in 2021, he was recognized by the American College of Psychiatrists, and he received the Distinguished Service Award. So he has published and contributed and given many teachings and trainings in cultural psychiatry, the interface between religion, spirituality, in psychiatric education, in diversity, inclusion, mental health equity, and psychiatry. So would everyone please join me now? I know we're all muted, but please join me for a silent applause, a round of applause to Dr. Francis Liu for this incredible, groundbreaking work. You can use the reactions button if you want to send him hearts and applause. Thank you, Dr. Francis Liu, for this incredible, groundbreaking, pioneering work. It certainly helped me tremendously as a medical doctor, trying to be what I was doing as my calling in Canada. With that, I'm going to turn it over to Dr. Francis Liu to speak with us today.
Well, thank you, Yvonne, for that incredibly warm and kind introduction. And I'm now going to share my screen. The title of my talk is the V code diagnostic category of religious or spiritual problem in DSM-4, which came out in 1994, and DSM-5 that came out in 2013. But as I was preparing this talk, I thought it might be helpful, since I have all of you here, to give you a broader perspective of how this category can be utilized. Because it's one thing to have the category, but it's another thing about, well, how does this fit into psychiatric evaluation and treatment? So I have no disclosures in any of the products described in my talk. My email is francisliumd@gmail.com. So feel free to email me with any additional questions, or happy to help. So I'm going to start with kind of a timeline of the Diagnostic and Statistical Manual of Mental Disorders. And as Yvonne said, this is kind of like our Bible, because the bulk of it are a description of mental disorders and the diagnostic criteria that are used to make the diagnosis. And the DSM-4 stands for the 4th edition. The first edition came out in 1948. And then the 5th edition came out in 2013. Now, a strategy that I and Robert Turner and David Lukoff utilized in our proposal was part of the plan, or the strategy was to include it under the umbrella concept of cultural issues. And I will illustrate that throughout my discussion here today. This new diagnostic category of religious or spiritual problem first appeared in the DSM-4, along with these other innovations in cultural issues. And one of these was the outline for cultural formulation that first appeared in the DSM-4. And then there was a DSM-4 text revision that appeared in 2011 or 2001, in which the diagnostic criteria remained the same, but the narratives were updated with references updated, and also retained and slightly revised in DSM-5. Now, another tool that emerged in DSM-5 was the cultural formulation interview, to provide 16 core questions that clinicians can ask patients and families to get the information for the outline for cultural formulation, which does include religious and spiritual issues. I will then just mention some book resources. I'll just mention very quickly a PubMed search and PsycInfo searches on religious or spiritual problem. And I'll end with 4 take-home points. So I'd like to kind of start with this preface. You know, Joseph Campbell used to say, at the bottom of the abyss comes the voice of salvation. And perhaps Scott Peck's lecture to the American Psychiatric Association annual meeting in 1993, and I remember attending it, was that bottom of the abyss here. He said, and this was later written about in his epilogue to his book, American psychiatry is, I believe, currently in a predicament because its traditional neglect of spirituality has led to 5 broad areas of failure: occasional, devastating misdiagnosis, not infrequent mistreatment, inadequate research and theory, an increasingly poor reputation, and a limitation of the psychiatrist's own personal development. Taken further, these failures are so destructive to psychiatry that the predicament can properly be called grave. Yeah, so I think he actually gave this lecture in 92 and it was published in 93. And I think some of our previous speakers have already given very poignant kind of first-person accounts of this situation. So David Lukoff is a professor emeritus now of transpersonal psychology, originally at the Institute on Transpersonal Psychology, and where he continued to teach until he retired maybe about 5 years ago. And Robert Turner is a psychiatrist in private practice in San Francisco. And the 3 of us kind of joined forces to write up this proposal to the DSM-4 task force for psycho-religious and psycho-spiritual problems. That was our original proposal. And I had met David in the 1980s through the Association for Transpersonal Psychology. We used to have annual meetings at Asilomar, and we've published about 25 articles together over the years. Now, initially, the task force was kind of lukewarm to take this up, and we were very fortunate, extremely fortunate, that we wrote up our proposal and we submitted it to a prestigious journal, the Journal of Nervous and Mental Disease. And Eugene Brody, who was the editor-in-chief at that time from Johns Hopkins, was quite supportive of this idea, and it was published in November of 1992. And that was the turning point, because by January of 93, the task force had decided to accept a version of what we proposed, and I'll detail that in just a moment. It was accepted as religious or spiritual problem. Instead of two, there's just one. And this was published in 94 as religious or spiritual problem. And then we have the other innovations that I'll talk about in a moment. And then in 1995, Robert Turner, David Lukoff, Tiffany Barnhouse, Ruth Tiffany Barnhouse, a psychiatrist in Texas, and myself, we published this article, which also appeared in the Journal of Nervous Mental Disease, which kind of gives a history, the complete history of the proposal and what happened afterwards. And this did win a Templeton Foundation exemplary paper in humility theology. Then in 2000, the text revision came out. Nothing changed. And then in 2010, there was a whole process leading up to the DSM-5. And I'll detail that in just a moment. But in 2013, the DSM-5 came out. The religious spiritual problem was unchanged in its text. The outline for cultural formulation was revised in important ways involving religion and spirituality. And then this new cultural formulation interview was created with 12 supplementary modules of additional questions that clinicians can ask to learn more about cultural issues. And I'll just mention that in a moment. Now, one more thing that's important for all of you is that later this year or early next year, the APA will be publishing DSM-5 text revision. Again, the diagnostic criteria will remain the same, but the text is all revised, including updated references, and I have participated in this, and I believe that it will be helpful. So this was the original proposal. We had psycho-religious problem, as you can see. These are troubling or distressing experiences. That's a very key term here, because we're not just talking about religious or spiritual phenomenon, but when those experiences become distressing in some way to the person. And so here are some examples: a loss or questioning of faith, change in denomination, conversion to a new faith, or intensification of adherence to religious practice or orthodoxy. Then we also proposed a separate category of psychospiritual problem. And here, as you can see, these are experiences that are troubling or distressing and involve the person's reported relationship with a transcendent being or force. Examples include near-death experience or mystical experience. And these two were mentioned because the published literature in this area was the steepest. And I mean, it seemed to be kind of self-obvious to us that these two should be mentioned, because there was such a deep literature, and Bruce Grayson and Ken Ring's work preceded our proposal, and others as well. Now, why did we do this? Well, there are many reasons, but one was to expand the differential diagnosis, because before this time, there was a tendency to lump religious or spiritual experiences, especially distressing experiences, as part of a mental disorder, as a sign or symptom of a mental disorder, as psychopathological. And so we wanted to, in our original proposal, point out that there were purely religious or spiritual problems, also mental disorders with religious or spiritual content, and these psycho-religious or psycho-spiritual problems that are not attributable to a mental disorder. Those are the three kind of buckets that we wanted to lay out, and that third bucket didn't exist before our proposal. And the rationale was to improve the diagnostic assessment when these issues came up, so that clinicians would have a diagnostic category to use, and to reduce the iatrogenic harm from misdiagnosis of psycho-religious and psycho-spiritual problems. In other words, the tendency of psychiatrists to label a mystical experience or a near-death experience as some either a psychotic disorder or some dissociative disorder or some mental disorder that causes problems, because misdiagnosis leads to mistreatment. So we wanted to create this category so that it would be seen in that way, and that hopefully, our thinking was to improve the treatment of such problems by stimulating clinical research and to encourage training in psychology, psychiatry, and other mental health professionals to consider the religious and spiritual dimensions of human life. Now, in the DSM-4, as I mentioned, there were these cultural issues that, again, were brand new for DSM-4. There was a big push from a task force from the National Institute of Mental Health, Dolores Perone, Office of Special Populations. She funded a work group to help propose how cultural issues could be incorporated in DSM-4, and they were somewhat successful, I'd put it that way. For example, in the introduction to DSM-4, there's a little description of cultural issues. In the narrative section of 79 of diagnostic categories, there are these culture, age, and gender features where you can learn about differential diagnosis issues, and I'll show you some examples in just a moment. And then the V code was added. And then in Appendix I, which is the 9th appendix, tucked away and forgotten, is the outline for cultural formulation and the glossary of cultural bound syndromes, again, to help us with the assessment process and with the differential diagnosis. So in the introduction, there was this sentence here that diagnostic assessment can be especially challenging when a clinician from one ethnic or cultural group uses the DSM-4 to evaluate individuals from a different cultural group. A clinician who is unfamiliar with the nuances of the individual's cultural frame of reference may incorrectly judge as psychopathology those normal variations in behavior, belief, or experiences that are particular to the individual's culture. It's hoped that these new features, the ones that I've just mentioned, will increase sensitivity to variation in how mental disorders may be expressed in different cultures and will reduce the possible effect of unintended bias stemming from the clinician's own cultural background. Now, if you would just, again, consider religion and spirituality as an aspect of culture, along with other cultural factors, which I'll describe later, you can see that if a clinician is an atheist and says, well, what brings you here today? And the patient says, well, I've lost my faith in God. God is punishing for my sins. That there could be a bias towards these patients by this psychiatrist. So it's, and there are all these biases here that are all involved. They could be intended, conscious, or explicit, or unintended, unconscious, and implicit. And I mean, homosexuality was a mental disorder in DSM until 1973. And the bias against religion and spirituality pervaded much of the last century. So here's an example of that culture, age, and gender features. Again, this was brand new in DSM-4. This is an example of kind of like a stop sign. Before you assume that hearing voices is a auditory hallucination, is psychopathology of like a psychotic disorder, before you go down that track, these are meant to be stop signs to alert you to the possibility, you know, what's cultural, what's psychopathology here. So that's, you can see that here. Here's another example. Voluntarily induced experiences of depersonalization or derealization form a part of meditative and trance practices that are prevalent in many religions and cultures and should not be confused with a mental disorder of depersonalization disorder. Then the V codes were part of DSM-4. I'm not sure if it was part of DSM-3, but these again are not mental disorders. That's the key term. That's the key take-home point. But they could be coded on Axis 1 with all the other mental disorders. There used to be a 5-axis system in the diagnosis, where Axis 1 was basically all of the mental disorders, Axis 2 were personality disorders. That was eliminated in DSM-5. But the idea is you could code, and this was all in the introduction to DSM-4, you could code a V code either by itself or there could be an unrelated mental disorder and a V code, or a related mental disorder and a V code. So you can have, it's not an either or, it could be a both and. And so this is what was in the DSM-4 and continues to be in the DSM-5. This is the exact language. As you can see, the task force decided to just clump it all together. And again, the key term here is a distressing experience. And they kept the religious examples, but as you can see, they eliminated near-death experience or mystical experience here. So there was a whole process of how do you get from DSM-4 to DSM-5, and there was a work group that worked on this, and there was a religion and spirituality work group that worked for 5 years on, you know, making proposals for DSM-5, and I was part of this along with John Petit, we presented ideas, and there were people assigned to different mental disorders to look and see where are the religious and spiritual issues. And so we reviewed all these topics and how do we update those age, gender, and cultural considerations. This led to a book, which again, I have no financial interest in this book, but that puts together all the work that was done here in regards to religious or spiritual issues and what we thought should be in DSM-5. And in fact, we did propose a revision to the language of religious or spiritual problem. As you can see, we proposed adding, you know, new religious movements and cults, life-threatening and terminal illness, as well as mystical experience, near death, psychic experience, alien abduction, meditation and spiritual practice related experiences, possession, and questioning of other spiritual values. You see, we proposed to the task force of DSM-5 to add those examples, which previous speakers had spoken about. So here's what happened in DSM-5. There was an augmented introduction, again, in section 2, which is where the mental disorders are defined and the diagnostic criteria. There were these culture-related diagnostic issues and gender-related diagnostic issue sections. The V codes were expanded, and I will come back to that. And then in section 3 of the DSM-5, there is a cultural formulation section, and that's where you can find the outline for cultural formulation that was revised and the new cultural formulation interview. And then in the appendix is this glossary of cultural concepts of distress, which replaced the glossary of culture-bound syndromes, which is a term that doesn't exist anymore in the DSM-5. Now, in the introduction, this is a very busy slide, but the important thing here is if you look at the blue here, when we speak about culture or cultural identity of the person, the idea was to look at the different influences of what's someone's cultural identity. And the take-home point here is that it goes beyond race and ethnicity. It's beyond one of those items. It involves an intersection of them, and I'll describe this more when I get to that section. So the person and the religion and spirituality is part of this cultural identity. Now, here's an example for schizophrenia for culture-related diagnostic issues. Now, this was actually in DSM-4 here, that ideas that appear delusional in one culture may be commonly held in another. And in some cultures, visual or auditory hallucinations with a religious content, like hearing God's voice, are a normal part of religious experience. And then this sentence was added in DSM-5 to further describe what this is all about. But again, these are the stop signs for us to think about. So let me give you a quick example. I asked the patient, well, have you been hearing voices? And the patient says, yes, I have been hearing voices. So again, the tendency of psychiatrists is to say, well, voices are auditory hallucinations, and that's a psychotic symptom. So that means the person has a psychotic disorder, see, a mental disorder, or a mood disorder with psychotic features, and we're on the psychopathology track. We're trained, psychiatrists are trained to do that. These are like stop signs. They're saying, wait, before you go down that track, ask, don't assume. That's the important motto. Ask, don't assume. So ask more, tell me more. You know, when do you hear God's voice? On every Sunday. How long has this been going on for? 30 years. Anybody else hear God's voice? So a whole family, in fact, the whole congregation hears God's voice. And you get the sense it's part of the person's culture. But we cannot stop there. We need to ask, well, has anything changed? And the person might say, well, I hear God's voice outside of church now. And how long? The last 2 weeks, every day. And the voice is telling me to jump off the bridge. Well, that's something else. So you see, it sometimes can be a combination of both. That's very important here. So the question, what's cultural or what's religious or spiritual? What's psychopathology? But the possibility of both. Okay, now the V codes. This is the language in the DSM-5 that introduces the V codes. As you can see, these are conditions or problems that may be a focus of clinical attention or may otherwise affect the diagnosis, course, prognosis, or treatment of a mental disorder. And the condition or problem can be coded as part of the diagnosis. But important to remember, these are not mental disorders. They're not mental disorders. Now, that's why this section tends to be forgotten because, you know, psychiatrists are into diagnosing mental disorders, which are billable, and, you know, and that's within our scope of practice, but these are not even mental disorders. So, you know, what are we supposed to do with them? Now, I'm very happy to report to you that this is beginning to change, and I'll describe that in just a moment. So here are categories of these disorders in DSM-5, and under each of the categories in white, there are specific distressing problems, not disorders here, distressing problems. So just to give you a sense of this, what this is all about. And then there's educational and occupational problem and housing and economic problems. So it should be obvious to everybody that the pandemic has caused problems in this area, such as kids can't go to school in person, people are unemployed, they have housing insecurity, food insecurity, unsafe drinking water, like what happened in Flint, Michigan, how their income has been impacted. These are all distressing experiences that could be coded, could be noted. Then we have this category of other problems related to the social environment. And there's the last one there, I think, is very relevant to what's been happening in the country here: target of perceived adverse discrimination or persecution. And that's what you have here. And this might also apply to people with religious or spiritual practices. They may feel, and that's listed there, as you can see, that can be a source of feeling discriminated against, even by mental health counselors and others. And certainly we've seen a whole boatload of these kinds of experiences that people are having. I don't need to go over it, but everything from George Floyd to AAPI hate to anti-Semitism, amongst many others. So patients may come in complaining of this, and psychiatrists and mental health counselors need to hear it and not to say, well, this is not part of any diagnostic criteria, so we're not going to pay attention to it. And then there are another category involves crime. And again, there's been lots happening in the country around that, and concerns about interactions with the police. And then finally, we have this category here where religious or spiritual problem lies. And indeed, it's the same language. The task force did not include any other examples. They simply repeated what was in the DSM-4. And then this is the last section here. So you have, again, hurricanes, climate change is a reality here. And indeed, that last category can be used for climate change. And climate change is now considered a social determinant of mental health. This is a busy slide, but just to say that, there's a whole other diagnostic system called the ICD, the International Classification of Disease, that the World Health Organization uses. And also, so the DSM codes are kind of translated into these into the ICD. And so the ICD uses Z codes, not V codes. So anyway, so now I'm going to come to the outline for cultural formulation. What you see in yellow is DSM-5, and what's in white is DSM-4. They're essentially the same. Again, 5 parts to the outline. This was the innovation in DSM-4. And there are 5 parts to the outline. The first 4 parts are interrelated fields of information that we ask the clinician to gather. And the 5th part is the call to action. How does that affect your differential diagnosis and your treatment plan? That's the payoff to gathering all of this history and figuring this all out. Now, I bring this up because there are very important aspects of religion and spirituality here that I wanted to bring to your attention. Okay, so as you can see, cultural identity, cultural concepts of distress, cultural stressors and supports, the cultural features of the relationship between the individual and the clinician, and the cultural assessment. And I mentioned, for DSM-5, there was the cultural formulation interview was created, 16 questions. There's a patient version that's printed in DSM-5 and an informant version, and the 12 supplementary modules, which are deeper dives on specific topics in the outline. And you would access them by Googling supplementary modules DSM-5. But the last 4 here are very specific populations or topics. And there's one, in fact, on religion, spirituality, and moral traditions. So if you have a patient where this is coming up, is this psychopathological? Is this part of the person's cultural experience, religious life, or whatever? This is the supplementary module that you need to access to give you additional questions to ask to help you understand what's going on. And so this is what the beginning of the core CFI looks like that's actually printed in the DSM-5. As you can see, it's not just a list of 16 questions, but there's on the left-hand column, a guide to the interviewer and specific instructions. And as you can see, question number 1 is, what brings you here today? So hopefully everybody's asking that question now. What brings you here today? And I'm just going to very quickly go through the 16 questions and relate them back to the outline for cultural formulation. So what brings you here today, and how do other people in the social network understand your wind illness, your problem, and what troubles you most? What are the causes of your problem? This is very important. What's the cause? Because there can be biomedical causes or psychological or interpersonal, but some people might believe that the cause of their problem is religious or spiritual or supernatural. And we need to understand that as part of patient-centered care. And what do people in the social network believe? So this relates to part B of the outline. And there are 3 subtypes here: idioms of distress, the presenting complaints, the cultural syndromes, which is like clustering, and the explanatory models. And also here, we're interested in the coping and help-seeking patterns, not only of professional care, but traditional, alternative, or complementary sources of care. So again, that means acupuncture, herbal medicine, Tai Chi, a religious healer. These things we are asking clinicians to understand as part of patient-centered care. Now, the questions of the CFI come a little later here on that. And then in the appendix, as I mentioned, there's this glossary of cultural concepts of distress, where we see 9 examples, and on the far left column are the actual names of these concepts, and in the middle, whether it's a cultural syndrome or an explanation or an idiom of distress. And some of these are related. So nervios is an idiom of distress. Ataque de nervios is a cultural syndrome, which includes nervios. And the right-hand column are places in the world where this is seen, but of course, patients come from all over the world. This is a cautionary tale of why we need to pay attention to this. It's a very famous book of a Hmong child, Hmong being an ethnic group from Laos, who had grand mal seizures, treated by a neurologist and pediatrician from a purely biomedical cause model and biomedical treatment of medications. And this led to a very unfortunate situation because the family saw it as a supernatural cause. They couldn't understand why medications were given. Led to non-compliance. The child had an extended grand mal seizure and was in a vegetative state for about 13 years before dying. So the next 2 questions of the CFI are stresses and supports. What kinds of support? What kind of stresses? And here it relates to part C of the outline. What's in yellow are the key take-home terms. What are the stressors and supports in the social environment, both local and distant events, and the 3 domains of religion, family, and other social networks. So religion was in the DSM-4, and social networks was added. So looking at this a little bit more carefully, interpersonal relationships are local. You see local social events across the 3 domains. And the social determinants of mental health can either be local by geography or time, or distant by geography or time. What do I mean by that? Take climate change. That's local in the sense that, a hurricane is bearing down on us. That's local. But climate change is also distant because it affects the whole world. And slavery, well, that still affects us now, all that's happening in the country, but it was also distant in time because it goes back 400 years. So here's a little diagram of 16 social determinants of mental health that Michael Compton and Ruth Shim have written about. There's a very important book, Social Determinants of Mental Health, that came out in 2015 by Compton and Shim, and those are in yellow, the 10, and then they've now added 6. So like climate change is in the upper right-hand corner, is one of their new ones. And you can see down below in the left is discrimination, adverse early childhood experiences. These are social determinants of mental health. Now, I just want to make mention that our current APA president, Vivian Pender, has made for her theme year this year, the socio-political determinants of mental health. And she has appointed a task force to look into this. I found out a few weeks ago that I'm one of the members of the task force. Dr. Dilip Jeste, an APA past president, will be the chair. Now, an example here of a stressor involving religious issues is the work of Ken Pargament and his concept of the spiritual struggle. The forerunner of this was the negative psychological coping that he wrote about in his first book, 1995. So his latest thinking is this idea of spiritual struggle. And these are examples, I think, of stresses and struggles, which I think are very much aligned with religious or spiritual problem. People could be having these kinds of struggles. They should not be considered mental disorders. So these are, things that he's written about. There's a whole body of literature on spiritual struggles. So now moving on to questions 8 to 10, it's about cultural identity. What's the most important aspect of your background or identity? And this relates to part A. This is what was in DSM-4. And as you can see, it mentions race, ethnicity, biculturality, and language. Now, very, very important in DSM-5 was this addition that explicitly acknowledged additional cultural identity variables that clinicians need to ask about. And religious affiliation, as you can see, is listed. And so two schemas to help you visualize this. Pamela Hayes, in her book, Addressing Cultural Complexities in Practice, uses the word addressing as an acronym. So you have a letter that corresponds to a cultural identity variable that we need to be thinking of. And you can see there is an R, so religion and spiritual orientation is there. But this is not a complete list because language starts with an L, and there's no L in addressing. And this is another schema here from thinkculturalhealth.hhs.gov, where you can see the various cultural identity variables starting at 8 o'clock, fanning across to 5 o'clock with spirituality, and how they intersect. The concept of intersectionality is so important here to help us understand who the person is in front of us. And this also intersects with health beliefs and practices and the environment. So questions 11 through 15 involve self-coping and past help seeking. And here we want to learn about the religious or spiritual healers. And there have been any barriers, because barriers that people have experienced in the past may be barriers that they have now. And then the two take-home points. These are the really take-home questions that clinicians need to ask. What kinds of help do you think would be useful to you at this time? And are there any other kinds of help that your social network has suggested? So this gets back to part B of the outline, and religious and spiritual healers need to be on people's radar screens. And then the last question of the CFI is this one. And this is so important here, so important. Sometimes doctors and patients misunderstand each other because they have different backgrounds. Have you been concerned about this? And is there anything that we can do to provide you care that you need? This just touches on the last part of the part D of the cultural features of the relationship between the individual and the clinician. And here we have identified the cultural identity differences and experiences of racism and discrimination in larger society may impede trust in the diagnostic encounter. That was added in DSM-5. And then ultimately, this is all important for the therapeutic alliance. You may have, so how do you operationalize this? I know I have 10 minutes left. Operationalize this. First is clinicians need to understand their own cultural identity. Then we need to compare the cultural identity of the patient with the clinician. So you have like a table. You have on the far left column the cultural identity variables, in the center the cultural identity variables of the patient, and then on the far right column the cultural identities of the clinician. And you look and compare and contrast these. And the third step is to see how these similarities or differences can affect the therapeutic relationship along these lines that we have, we're always concerned about these things. And the last step is what would help the clinician provide optimal care. Now, sometimes our cultural identity matches. So, some patients, for example, would like a Christian psychiatrist or, someone from their religious or spiritual background. That does come up, and sometimes that can be important. Language is another example. If I speak only English and the patient only speaks Cantonese, even though we share the same ethnicity of Chinese, we're going to have some problems in communicating and getting history. Other times, it can be just, how do we increase our knowledge and skills concerning all of these areas, including religion and spirituality. And this might involve PubMed searches, reading books, getting a cultural or religious or spiritual consultation. And this is when we come to the last part. This is the call to action. And this is what is said here is to summarize for the diagnosis of mental disorders and other clinically relevant issues or problems. Those are the V codes as well as treatment. And this is the most challenging, is how do you bring it all together? And so ask, don't assume, get a cultural, religious, or spiritual consultation. So now, back in 2006, the APA did issue a resource document on this topic and said that psychiatrists should foster recovery by making treatment decisions with patients in ways that respect and take into meaningful consideration their cultural, religious, spiritual, and personal ideals. And I'm very happy to report that just this April, just a couple of months ago, the APA issued another resource document on the ethics at the interface of religion, spirituality, and psychiatric practice. It's about 6 or 7 pages, and we'd only have time for me to just quote a part of the conclusion. It is important for psychiatrists to explore and understand the religious and spiritual values of their patients as part of their assessment and treatment of mental disorders. When possible and appropriate, psychiatrists may incorporate their patients' religious and spiritual values into treatment, just as they would for their patients' other values, other cultural values. Psychiatrists are encouraged to consider and remain open-minded about their patients' preferences for non-harmful but spiritually valuable practices or treatments as an adjunct to standard mental health care. And so this is readily available at the APA website. So again, in terms of diagnosis, we want to make an accurate diagnosis by having a complete differential diagnosis. Misdiagnosis can lead to mistreatment by the ways that we have talked about here today. And how do you do this? Well, the first thing is to review those stop signs in the DSM-5, the culture-related and gender-related diagnostic issues sections, because they'll give you differential diagnosis, like that hearing voices. Well, it's not necessarily an auditory hallucination. It could be part of the person's religion. As well as at the disorder level. We know that Blacks are overdiagnosed with schizophrenia, for example, and that's will be coming out in this new text revision. All of these will be updated with new material, new references. And secondly is that we need to review and add those V codes that map onto social determinants of mental health so we can address them in the treatment plan. And
We
that
have
includes
5 minutes. We have 5 minutes,
right,
Francis.
thank you. Right. Okay. So for the differential diagnosis of what we're focusing on today is, what is religious or spiritual phenomenon? What are distressing experiences involving religion or spirituality that could be a religious or spiritual problem, but is not part of a mental disorder? And then what are mental disorders that people might be having? And to remember the possibility of 1, 2, or 3 of the above items could exist. It's not an either or. And I think a previous speaker brought this up. Then in terms of treatment planning, there's the process of negotiating and managing a treatment plan to maximize adherence and compliance. And we as clinicians are interested in this with every patient every day. So the idea is put on the cultural lens, see what more you can see. And this does include religion and spirituality. And then from the content, there's the bio, the psycho, and the social. I'll just quickly touch on the latter two, is to respect family and patient expectations, the importance of respect and empathy, as well as boundaries. We have the usual treatment psychotherapy decisions in terms of what modes of therapy, but the 3 take-home points. What are the cultural modifications in therapy? And again, that includes religion and spirituality. What are the therapist's characteristics that would facilitate or hinder treatment? So if you're an atheist and a patient is very deeply religious, if you're not careful, you could have that bias leak into your treatment, as an example. And then what are the V codes and the social determinants of mental health that need to be addressed? And then at the socio-cultural level, again, keep in mind family, religion, spirituality, other social networks, working with other care systems, and the faith and spiritual organizations and leaders. So books for your future reference here. This is the best book on the outline for cultural formulation. It has a new chapter on religion and spirituality in that 2nd edition, and the handbook on the cultural formulation. There are chapters on the supplementary module on religion, spirituality, psychiatry. This is an online training on the CFI. Now, in terms of a PubMed search that I did in 2019 on this topic of religious and spiritual problem, both in PubMed and in PsycInfo, there was really very little written on this still. That touched on different topics, but it's really, the research is still early on. So the 4 take-home points in my last minute here is use the cultural formulation interview to gather history for the outline for cultural formulation. This will aid in the differential diagnosis by including religious or spiritual problem if that comes up. And this will help us with patient-centered treatment planning. Use of the CFI for the outline for cultural formulation and consideration of the religious or spiritual problem will aid the implementation of a WPA position on this topic. And the World Psychiatric Association back in 2016 did issue a similar sort of position statement on this. The use of religious and spirituality in problem in research is young, and the DSM-5 text revision will have important changes. So my time is over, and I'm ready to take questions either through chat or directly.
Must unmute myself or else people can't hear me. Thank you very much, Francis. That was an incredible presentation about this incredibly groundbreaking work you've done and you are continuing to do. So thank you very, 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 very much. So people, you can enter your questions into the chat. We do have a couple questions there already, and I have a question too, but we'll go first with the ones that are written in the chat. So this one comes from Terry Daniel to you, Francis, and she says, I'm a university professor and hospice chaplain doing research on religious trauma syndrome and toxic theology. For example, people who experienced abusive religious indoctrination as children or joined religious cults with extreme belief systems. Can you speak to the variability of this syndrome as a DSM-worthy diagnosis? So she's calling it religious trauma syndrome. And she said, or another way to say it is spiritual abuse. Is spiritual abuse considered a religious problem?
Okay, well, I think that I do think that what was written about there could be considered certainly a religious or spiritual problem. In our writings, in our original proposal, we did talk about cults, that people can have really distressing experiences around cults. And so I do think that for right now, you have religious or spiritual problem. You could certainly use that as a diagnostic category, as a handle. You see what I'm saying? It's a handle to point to the fact that you need further religious or spiritual assessment, first of all, and then what are the interventions that can help a person break out of this, you know, so in other words, it legitimizes treating this problem, not as a mental disorder, but as a distressing experience. And there ought to be treatment methods related to it. And people have written about these things. And I'm just providing you the language of DSM-5 so that, you know, you can relate to to psychiatrists and others, that this is a way of doing it. Now, in order to create a new diagnostic category, like a mental disorder of religious trauma syndrome, this gets into a whole, okay, any proposals for a mental disorder raises the bar. I mean, tremendous amount of evidence has to be presented. There's a whole method that the APA has created because they're very worried and very concerned about the expansion of mental disorders in numbers, you know, kind of grade inflation, if you will. And so they've raised the bar now in terms of having, in order to make it an actual diagnostic category for a mental disorder. And especially around trauma disorders, the work group there has been very reluctant to make too many changes. I mean, for example, racial trauma syndrome, people have written about this, and again, it's not getting into the DSM. So as a mental disorder. Now that's a two-edged sword. I know I'm talking too much now, but are you sure you want to make that a mental disorder, you know, religious trauma syndrome? Because the tendency might then to kind of blame the individual. What's wrong with you? That sort of thinking, as opposed to looking at the environment, the social environment that the person's in. You know, many of those abuse categories in the V codes can, you know, they don't, there are some there that do talk about like social network abuse sort of situations. So there are other V codes that you can use. Okay, we probably should move on to the next question here.
Okay, we don't have a lot of questions, so I will actually give you the next question. I wanted to ask you, you know, the two categories, the two types of experiences that you tried to include, which were not included on both your attempts, the mystical experience and the near-death experience, and these are still being mislabeled to this day. And you're aware of that, and I'm aware of that they're being misdiagnosed to this day. What do you think are some of the biggest obstacles why we're having difficulty to get acceptance about the near-death experience and mystical experiences? And what are some of the ways you think that we can overcome some of these obstacles?
That's a great question. That's really a key question. I think that David Lukoff and I and others, after we tried in 2010, as I showed you, we did try in 2010. I think that we kind of got discouraged. uh, and I think the only way to think about this is, you know, this is a long journey, you know. So eventually there will be a DSM-6, you know, probably maybe in 8 to 10 years, there'll be a DSM-6. And, you know, we can continue to do the research and write the proposals and try to change the language then. And maybe, you know, maybe there'll be greater appreciation of these issues. I'm certainly very encouraged that that new resource document came out. I would urge that everybody take a look at it. And if anybody has trouble accessing it, just email me at francislewmd@gmail. I'd be happy to send you the link or send you the actual resource document, because it really does, that was actually put together by the ethics committee. The ethics committee of APA put that out. And so I think it's loaded with a lot of useful information that would be very good jumping points to try to get this into the DSM-6.
We have another comment here. I'm not sure if there's a question in it, but perhaps you'd like to reflect on this comment. This one's from Rudy, and Rudy says, as a former soldier, I had a near-death experience. And while there were some negative aspects of my near-death experience, the medications the VA gave me induced suicidal ideation that has lasted for decades now. I guess I was not sure if I should try to make it all go away, as I never really felt like I belonged here. It has been a long journey, but he says, I'm glad the NDE by itself is not now considered a mental illness.
Yes, no, this is so important, you see, is that again, I don't know the details of the experience here, but just reading between the lines that the NDE was somehow diagnosed as part of a mental disorder, whatever mental disorder diagnosis they gave him. And medications given to try to alleviate the symptoms. And this is typical. This is kind of what psychiatrists tend to do. And I think we just need to continue through the work of Spiritual Awakenings International, really, and others to keep bringing this up, that you know, that it's not by itself not a mental disorder, and really does need to be addressed in a different way. That by calling it a symptom of a mental disorder, you see that psychopathologizing leads to mistreatment and all of these terrible effects. And so that was our intent from the very beginning, over 25 years ago.
We do have a couple more questions that have come in. This one is from another physician, Dr. Shira Taylor from Toronto here. And she said a lot of the V codes point to social problems that create mental distress. Psychiatry, however, focuses on treating individuals. Does this suggest a need for greater advocacy on the part of physicians and others around the social problems that generate distress? This includes around the ways in which spiritual experiences are pathologized by our healthcare system.
Yes, absolutely. And that's why I'm so encouraged by Dr. Vivian Pender's theme for this year, so that, just stepping back here, the big picture is this. In addition to the biomedical causes of mental disorders and the psychological determinants of mental disorders, we're making the point here, there are socio-political determinants of mental disorders. And we need to understand them, we need to address them. And this, of course, includes the way we are causing iatrogenic harm by pathologizing these STE experiences.
Our next sort of comment / question is from Nandini, and she writes, bullying and racially based trauma, among other traumatic experiences, can leave scars and create health issues, both physical and mental. Perhaps there is resistance among professionals towards accepting this?
Yes, I think it's underappreciated, and there was the V code of social exclusion, and when you read through the definition, and I didn't have time to include that in my slides, it did explicitly include bullying. So there is a V code for that under social exclusion and bullying. And again, we need to just bring this up to the awareness of mental health professionals that this has to be taken seriously, and is not, it needs to be recognized as affecting people either directly just by itself, or, as I indicated, could affect the diagnosis, course, and prognosis of mental disorders. So as part of the comprehensive treatment plan, we need to diagnose these V codes, and we need to address them in the treatment plan for holistic patient-centered care.
Thank you for that, Francis. The next question comes from Linda. She says, if an NDE or STE experiencer is found not to have a mental illness because of proper DSM screening, where are the experiencers sent to or to go to next?
Right. Well, this gets into, again, optimally in the optimal world, the psychiatrists or mental health counselors or clinicians need to be aware that that if the person doesn't have a mental disorder, then they ought to be referred to helpers that can work with them in a way that would be useful for the patients. And again, the tendency right now is that that's not really thought about, so it kind of just drops off. But we ought to be having soteria houses and other places where people can be, and that again continues to be a problem.
Yeah. Well, we are almost out of time, but we have one more question I'd like to give to you. And this one is from Shala. And she says, has there been or will there be any physiological correlative studies examining the relationship between religious and spiritual problems and STEs?
Yeah, I think that's a very good question, and certainly, people have looked into, have done some studies in this area. I'm not up on the latest literature, but certainly brain scans and other forms of brain imaging have been used to look at religious or spiritual phenomenon. And I'm sure other people who have studied these phenomenon may have the latest information on that, but that would help. That might help the, the kind of the biologically based psychiatrists to believe in these experiences that people have.
Anyway, thank
Well,
you.
thank you again, and happy to answer any questions by if people could email me if they want, let me know if I can be of any help. Okay, thank you very much.
Thank you, Dr. Francis Liu. That was an incredible, wonderful presentation. So thank you very much. And thank you for all that you've done. And congratulations on your induction into our SAI Circle of Honor.